I'm very pleased to have the opportunity to talk with you. I used to come down almost once a year until the virus prevented that. I also want to say that one sport that I follow is professional cycling, and I was very distressed to hear that your champion, Egan Bernal, had a very serious crash recently. So I wish him the best going forward. So I've been asked to talk about electrodiagnosis, and so I don't have any disclosures. And so electrodiagnosis is the general term for the studies that we do to assess peripheral nerves, neuromuscular junction, and muscle. And with these studies, we're trying to estimate the underlying pathology. And we have three major test categories to do this: nerve conduction studies, repetitive nerve stimulation and jitter studies, and the EMG or electromyogram. I'm only going to talk about nerve studies and muscle studies related to neuropathies and muscle disease, and I will not talk about repetitive nerve stimulation and jitter studies except briefly. So my outline is to talk to you in two separate talks linked together, one about nerve conduction studies and the other about EMG. And for both of them, I want to review the underlying principles, the pathology that we're trying to estimate, and some of the pitfalls. I know the audience consists of neurologists who perform these studies, neurologists who just review the studies, and their primary care physicians and students. And I hope to be informative to all of you. On to nerve conduction studies. When we look at nerves overall, axonal neuropathies are by far the most common form of neuropathy we encounter. And then there is a category of chronic demyelinating and conduction neuropathies, which, while rare, are very important to diagnose because they're one of the few classes of treatable neuropathies. And what we're focusing on today in chronic neuropathies would be chronic inflammatory demyelinating polyradiculoneuropathy, or CIDP, and a number of variants, plus multifocal acquired demyelinating sensory and motor neuropathy, also called MAD-SAM or the Lewis-Sumner syndrome. And then briefly talk about multifocal motor neuropathy with conduction block, or MMN, and how we can help distinguish these demyelinating immune-mediated neuropathies from axonal neuropathies is the key issue. So you can say, well, why this talk? It should be straightforward, but it turns out that there are quite a few inaccurate diagnoses for CIDP, and up to 50% of them really do not fulfill essential criteria. And the error is calling axonal neuropathies with mild slowing axonal neuropathies with demyelinating features. And this is what I want to focus on as we go forward. So why are these errors? Well, it could be that people do not appreciate the underlying pathology that they're trying to estimate. There may be different definitions in their mind of pathology. And the key here is there are likely different interpretations of the data. And people are not using published criteria. So what is the role of electrodiagnostic studies? As I mentioned, it's to try to estimate underlying nerve pathology. And I divide it up into three broad categories: primary demyelination, primary axonal, and primary conduction block. Of course, there may be mixed patterns, but then the goal is to choose what's the primary pattern over the secondary pattern. Now, how do we know what the pathology is that we're trying to estimate? And so that comes from pathologic correlates, but really the data are relatively sparse, and most of these demyelinating and conduction block pathologies come from nerve biopsies. And there's a growing understanding of a category where there may be no pathology. under the microscope. In other words, it's pathology at the node or paranode that may cause physiologic blockade of conductions. Now, for this part, I'm focusing on nerve conductions for the diagnosis of neuropathy because the EMG is much less sensitive overall. It can tell you if there's axonal loss, but not the amount of axonal loss, nor whether it's primary or secondary axonal loss. Let's talk a bit about nerve anatomy and pathology. And so I've got here a standard diagram of the peripheral nervous system. And so here is the spinal cord. And on this side, you see our small diameter unmyelinated fibers. And this side are the large diameter myelinated fibers. Now, you can also see with this dotted line that this is where the dura is. And so within this U-shaped area is where there is spinal fluid. And we can sample that looking for any kind of immunologic breakdown of the blood-brain barrier. Now, all of these nerves, as I've linked together in the blue, are in a peripheral nerve. However, most of the symptoms that patients describe when they come to you are based on damage or loss of function of myelinated motor nerves and myelinated sensory nerves. So the ones in the red are what we're going to focus on. In addition, the nerve conduction studies really only look at these large myelinated fibers. And so you can see that the ones on the left in the previous slide are in the majority, but we're discounting them. Now, the range of conduction velocity of these fibers is approximately 40 to 50 meters per second. And I put an arrow here because most of the measurements we make for timing are really based on the single fastest one or two fibers. Now, we talked a bit about what happens if there's pathology at the node of Ranvier. And so here's what it looks like structurally. Here's the axon that narrows down at the node of Ranvier, and you can see in higher magnification that it is narrowed down. And then here is the myelin along the sides. The myelin has some special changes where it narrows down. And what you have in this area here is a large number of sodium and potassium channels that are responsible for generation of the action potential. And you can envision that if these are not functioning, the action potential would die out. Now, normal nerve pathology, when we look at it under the microscope, is in cross-section, and you see a large number of heavily myelinated fibers. And here are some of the small myelinated fibers and unmyelinated fibers. And if you have a teased fiber preparation, you can see here's a node of Ranvier, and this is the internode region. And then it ends in another node of Ranvier and another internode region and onward. And you can see that the thickness of the myelin is relatively uniform. Now let's talk about axonal pathology, primary axonal pathology. Now I've drawn two red ovals here because these neuropathies clinically follow a stocking glove distribution. And so it's length dependent, which means that the symptoms begin to progress up as a stocking. And when they reach this length nerve, peripheral nerve, that's the same length of the peripheral nerve going to distal upper extremities. So the key when you think about a person with a neuropathy is this clinical stocking glove pattern. And therefore you can see there's axonal loss of motor and sensory fibers with the possibility of regeneration. Under the microscope, what you see in cross-section is a paucity, very few nerve fibers, and the myelin may not be as thick, meaning some of these may be regenerating. Then when you look in teased fibers, you can see that the myelin no longer has an axon to wrap around, so the myelin begins to degenerate and get into blobs. And here you can begin to see an axon growing out to regenerate. In contrast, in primary demyelination, because this is immune mediated, the pathologic process is disseminated in the blood, and it goes to all regions of nerves and all nerves. So here the key is that at the time of presentation, there's numbness and tingling and weakness, not only distally, but proximally in the legs, and not only distally in the arms, but proximally in the arms. And this is a very key characteristic to seek out, because if patients do not have this proximal plus distal, lower extremity plus upper extremity set of symptoms and signs, then this is highly unlikely to be primary demyelinating. But what you see here is, in theory, intact axons, but something's damaging the myelin. And it can regenerate, remyelinate, and that's what you get here in a remyelinated axon. Under the microscope, because there's frequently secondary axonal loss, you will see fewer axon profiles, and you may see scant myelination here, or you may see disrupted myelination in the form of onion bulb formations, which is attempted remyelination several times in the setting of demyelination. And then with T's fibers, you can see that the axon is intact here, but the myelin now has a bigger gap at the node of Ranvier, and as it begins to remyelinate, the myelin is thinner, or there may be no myelin in a segment of the internode. And then we get to primary focal conduction block. And so here, it's going to be in a mononeuropathy pattern. And if you have multiple nerves, it's going to be focal multiplex distribution. What I'm not talking about is a vasculitic neuropathy, but this is where you have some damage to either 2 or 3 segments of myelin so that the conduction is interrupted, or you have a focal change at the node of Ranvier. And so here we have back the node of Ranvier, which I showed you before, and you have your high concentration, especially of sodium channels, where the action potential is regenerated. So here's another teased fiber preparation, similar to what I showed you in previous slides, where there's an intact node of Ranvier with almost no space. And then here is one where there is a stripping of the myelin, and so the axon action potential would die out when it gets to here, and hence conduction block. Or you can have antibody blockade recognizing some of these ion channels, and then there's no regeneration of the action potential. And so we are beginning to recognize in CIDP that there are a number of proteins in the perinodal area that are very important for the maintenance of the structure. And if there are antibodies to them, such as neurofascin 155, contactin 1, and contactin associated protein, or Casper, which are in this region, if antibodies attach here and block their function, then you can have a physiologic axonal block or conduction block. Now, with that as a background of what we think the pathology looks like, let us go into nerve conductions. What I want to do is to first deconstruct a nerve conduction for you, and then we'll apply that to these pathologic states. Now, we can study separately sensory and motor nerves based on where we put the electrode. So when we study sensory nerves, we're stimulating the whole nerve electrically. And then what we're stimulating is nerve fiber action potentials. and we're recording in sensory nerves from the nerve fiber action potentials. There may be 6,000 nerve fibers, and each action potential is tiny. So the sensory nerve action potential, SNAP, SNAP, is in microvolt amplitude. Therefore, there's a floor effect. If you lose 65% of your sensory nerves, the remaining ones are insufficient to register a response under your electrode. Furthermore, there's a marked amplitude loss over segments. And so sensory nerves are less useful in trying to estimate underlying pathology. When we go to a motor nerve, we're stimulating all the motor fibers, which may be 200 or 300 going to the muscle. But once the nerve is in the muscle, it branches many hundreds of times, and each muscle fiber produces its action potential. So the sum of all these gives you a compound muscle action potential, or CMAP, in the millivolt range. There is a loss with amplitude, but because the amplitude is larger than it is with sensory nerves, you can actually record the response if only one fiber remains. Now, there's also something called the F-wave latency, which is part of the motor study, and that's also a metric that we use. So let's go to the compound potentials, and we're going to focus on motor nerves and not sensory nerves because of the reasons I just gave you. So the compound potential has an amplitude or area. And so we're going to probably talk about amplitude most of the time, but area and amplitude are directly related. So the amplitude of the response is roughly proportional to the number of axons. The reason why it isn't equal to the number of axons are because of three caveats here, which I will go into as we go on. So the first metric that we get is the amplitude of the compound potential. Then we get four metrics that are related to timing. And timing is largely proportional to the integrity of myelin. So the first one is the distal latency, the second one is the F-wave latency, and the third one is the conduction velocity. As I pointed out earlier, these are really based on the fastest fiber arriving under the microscope. But you may have several hundred fibers. So how do we measure the contribution of the remaining fibers? We do that through the negative peak duration of the compound potential, which I will show you a little bit in another slide. And so that is, if the fastest fiber is 50 meters per second, it's showing you the contribution of the fibers that are slower than 50 meters per second. I also want to point out here that if you have a severe neuropathy and you get no response, like no sensory or no motor response, it tells you it's severe, but it doesn't tell you any information about underlying pathology. So you always have to go to a nerve where you can get a response. If there are no responses in the leg nerves, move up to the arm nerves. Now let's look at a compound muscle action potential. And so it is made up, as I said, of all the single muscle fiber potentials. So here we have a single muscle fiber potential that arrives very quickly. Here's another fiber potential, a third, and a fourth. And so this is connected to a slower axon, a still slower axon, and the slowest axon. And you can see that by convention, here's a line across here. Negative is up and positive is down. So the arriving negative phase of the first potential is going to somewhat add up to the negative of the second potential, but the positive of the first potential is going to subtract from the negative of the second potential, and so on. So what you get is phase cancellation. And so the ultimate amplitude of this potential is 111 microvolts, which represents some late positives being canceled out by earlier negatives, whereas the total sum of it would be 519 microvolts. Now, I'm also going to show you here that if we just take and make a symbol of these, which I'm showing you here, I'm going to construct some potentials to illustrate some points as I go forward. Now, here's a key slide I want you to consider. When you look at a compound potential on your screen, this is what I think we all see in this dotted line. We see an amplitude and a duration, and then we see the shape of the outline. So this is a very smooth shape. So these, I think, are the three key factors. When we get our EMG machine to list the factors, most EMG machines list distal latency first. But I hope to argue with you that the most important number to see first is the amplitude. And then the second most important number is the duration. And then comes distal latency and conduction velocity. So I have reordered these on my machine. So the first number I consider is amplitude. And in the subsequent slides, I want to show you why. Now, when you look at segmental motor nerve conduction, so here you can see stimulating at the wrist, below the elbow, above the elbow, in the axilla, at Erb's point, that phase cancellation that I talked to you about results in the amplitude of the most proximal response being 21% less than the amplitude of the most distal response. And then the distal latency increases a little bit because you're covering a longer distance. And the slowness of the fibers spread out, so your negative peak duration here is 11% longer than it is here. So these are the effects of normal phase cancellation and normal temporal dispersion. Now, let's go back to the amplitude of the compound potential and the first caveat. If you have axonal loss, and here I'm showing axonal loss distally due to a peripheral neuropathy, here proximally due to damage to a nerve root, and in the motor neuron due to ALS, you're going to get denervation of these muscle fibers, but you have collateral reinnervation from the surviving motor neurons. And here's a simple example. If you had only two fibers and you lost one nerve fiber and you had complete reinnervation, the number of motor units would have gone from 2 to 1, but the amplitude of the compound potential would have been unchanged because every muscle fiber was innervated. So now this extreme does not happen, but keep in mind that your compound muscle action potential can be greater than your lower limit of normal with loss of up to 80% of your axons. Therefore, when you have an amplitude that's about the level of your lower limit of normal, don't think that's a normal number of axons. Be concerned that there may be a marked loss of axons. And the second caveat for the amplitude is abnormal temporal dispersion. So this slide looks complex, but let me take you through it. It's using an analogy of runners. So if you had a large number of runners and they were very consistent, the fastest runner ran 6-minute miles and the slowest runner ran 7-minute miles, over a 1-mile race, there would be 1 minute of dispersion between the first and the last. And the amplitude of them crossing the line, because they're bunched up, as signified by the blue line, would be relatively high. Now, if you have the same runners, but they're going over 10 miles, they're dispersed by 10 minutes, and the volume coming over the amplitude, again, by the blue line is lower. And that's what I showed you on the previous slide. Now, let's say that we have the same runners, and the fastest runner is still running at 6-minute miles, but the 7-minute milers are now stretched out to 8-minute miles. Then you can see that the arrival time, the negative peak duration, is much longer, and the amplitude is of the volume crossing is lower. So same number of runners here as in here, but the amplitude of them crossing the finish line is less. And that's due to slowing or abnormal temporal dispersion. And so here it is looking at it a little more physiologically. Here's the compound potential made up here of 3 individual potentials arriving normally. Here the potentials are spread out, and so you can see that the amplitude is dropped because of greater phase cancellation, and the negative peak duration is longer. And there's a change in the waveform shape from being very smooth up here to being more ragged here. That's that third element I recommended you look at. Now, here comes the key reason why you want to look at amplitude first. So here is back to our compound potential, looking at just the 4 individual responses. All 4 are present. The timing of the distal latency is by this fastest one, and the conduction velocity is by this fastest one. If by chance alone in the neuropathy, the first one dropped out, or was damaged, or was lost, then the timing now comes from the second healthy axon conducting at its normal speed, but the distal latency is now 3.9 and the conduction velocity is 50 meters per second. Now, if all of the largest, fastest conducting fibers dropped out and only a few slower ones are remaining, the distal latency is now markedly longer and the conduction velocity is markedly slower. But this is not due to demyelination. This is due to the remaining few normal fibers conducting at their normal speed. Therefore, if your amplitude is low, begin to think that you may have lost these and you need to interpret these metrics, timing metrics, a little more carefully. Therefore, how much axonal loss can you attribute, how much slowing can you attribute to axonal loss, and how much slowing can you attribute to actual damage to myelin? So there have been some modeling where you can model nerve fiber and nerve fiber loss. And if you have a random loss of fibers, the amplitude does fall linearly. The more you lose, the more amplitude drops. But the distal latency increases when 90% of the fibers are lost, and the conduction velocity decreases when 80% of the fibers are lost. But if you lose large fibers preferentially, 7 to 12 microns, then the amplitude drops quite rapidly when these are lost, much sooner than the 90%. And the distal latency begins to increase when you're losing fibers that are 8 microns and larger, and the same thing for the conduction velocity. So it sort of depends upon which fiber types are lost in the neuropathy. Now, let's take a physiologic model. Now, the one nerve model that we would agree is pure axonal would be amyotrophic lateral sclerosis, or ALS. So if you take empiric data, in other words, take all of your nerve conduction studies from people who were ultimately diagnosed as having ALS, and look at the values you have, it turns out that people with ALS and even marked axonal loss, their conduction velocity, the remaining fibers, will be greater than 75% of your lower limit of normal. The distal latency will never be less than 125% of your upper limit of normal, and the same for the F wave. So if you turn this around, you can say that if your conduction velocity is slower than 75%, or distal latency is greater than 125%, then that is more than you'd expect from axonal loss, and then it likely includes elements of demyelination. Although this wasn't looked at, the negative peak duration wasn't looked at in the ALS patients, but the same thing, if your negative peak duration is 125% of upper limit of normal, then think about, again, elements of demyelination. So this slide shows you that with ALS, there clearly is a loss of large diameter fibers. So this is an L5 ventral root, and you can see in a control, these are the larger fibers in the 11 to 16 micron range. And here are two cases, and sure enough, the large fibers are lost. When we go over here to CIDP, this is a sural nerve, granted a sensory nerve. Here is the normal cross-sectional picture, many nerve fibers. Again, you can see this is 10 microns. There are a lot of large nerve diameter fibers. And here are two patients looking at the sural nerve, and clearly there is a loss of large diameter fibers. So what I showed you on the previous slide related to ALS holds. When you lose large diameter fibers, you're going to have a degree of slowing due to loss of fibers and not due to demyelination. Let us talk about conduction block. So there's conduction block, true conduction block, and apparent conduction block. So obviously, conduction block is when an action potential does not go by a focal point along the axon. And a corollary to that is that there will be normal conduction of the axon distal to the block and normal conduction of the axon proximal to the block. Now, if you have 100 motor fibers and you only have block in one or two at a certain site, you may not detect this. How many fibers have to have a block before you can detect it? That isn't clear, but there needs to be an appreciable number of nerve fibers blocked. Then we can have focal conduction block, and we can have apparent conduction block. So the focal conduction block is a reduction of the proximal stimulation compound potential compared to the distal compound potential. In other words, when you stimulate proximally, the fibers are blocked and they cannot show up in the distal response. An apparent block is where there is a reduction in the proximal response, but it's due to abnormal temporal dispersion and greater phase cancellation. Now, when we talk about block clinically, we can have blocks of a limited number of fibers at multiple sites in a whole nerve, and so they can add up, which I'll show you in a slide. And you can have also focal conduction block and abnormal temporal dispersion. And at times it can be challenging to sort these out. Now let's take true conduction block. First, we'll take a very simple nerve that has only 4 fibers in it. We're stimulating distally, and then we're stimulating proximally. And due to the different arrival times, slightly spread out here, and the different phase cancellations, there'll be up to a 10% drop in amplitude due to normal temporal dispersion. Now, let's say we have the same fibers here, but 2 of them have been blocked. So now when we stimulate proximally, we're only getting 2 of them across. They have their normal conduction velocity. In fact, your negative peak duration may be a little bit less, but you can see the amplitude is 50% reduced. So the key here is a reduction in amplitude, but no increase in the negative peak duration. Now here is apparent conduction block due to abnormal temporal dispersion. Again, the same top nerve, normal temporal dispersion, stimulating distally, here's the response. Here's the proximal response, 10% lower. You here have 4 fibers, the same 4 fibers, but these have been spread out because they're conducting more slowly. So your negative peak duration is very much longer, but the amplitude is lower because of the phase cancellation. So again, you would have lower proximal CMAP amplitude, but you would have associated with it much longer negative peak duration. And then what happens if you have a very low compound potential? In other words, in this example, say you only have 2 fibers remaining in your nerve. They're both normal because you've had just conduction, because you've had axonal loss, and these are the remaining normal fibers. When you stimulate proximally, you get a low potential, and I'm putting it here as less than 1 millivolt. When you stimulate proximally, you get a very much lower response, but it's not due to conduction block. It's due to the fact that this was a slow conducting fiber and it got stretched out. And so the phase cancellation resulted in a lower amplitude. Again, how do you detect that? Well, the negative peak duration did not increase. But as a caveat, which I'll show you, be very leery of talking about primary demyelination if the amplitude of your distal compound potential is less than 1 millivolt. So let us turn to the practical aspect of what do we see. So demyelinating nerve conduction findings. And so this will be amongst the 300 fibers that you have in a motor nerve. You may have some focal demyelination of one at one site to another nerve at another site, etc. And so you're going to have some degree of slowing of conduction along fibers, resulting in some degree of abnormal temporal dispersion, in turn causing an increase in the negative peak duration, greater phase cancellation, and a reduced proximal compound potential area and amplitude. Now, because this is based on the distance of conduction, as in the runners from 1 mile to 10 miles, the longer the nerve segment you stimulate over, the greater chance you have of seeing mild degrees of demyelination. So the ulnar nerve is a good example to stimulate not only at the wrist, below and above the elbow, but also up into the axilla. So here is another model where we have 9 nerve fibers. You can see small diameter and large diameter nerve fibers. And here we're stimulating distally, and these are all of the motor nerve individual potentials that summate to this compound muscle action potential. Then we stimulate proximally over a greater distance. There's phase cancellation, and this amplitude is a little lower than this amplitude. And here is a real life example. Now, if we have multifocal conduction block and slowing, as you can see, interruptions of the myelin, when you stimulate distally, you do activate all of the fibers, more abnormal temporal dispersion, so it's lower in amplitude than the healthy nerve. But when you stimulate proximally, there's more distance for pathology to occur, and this fiber, and this fiber have been blocked, plus there's greater slowing, so the amplitude is very much lower. Here is a real example, and again, I point out that the distal latency is longer. These latencies are longer so that there's slower conduction velocity, negative peak duration is longer, and the waveform shape is ragged. And then here's a model of pure conduction block. Here's the normal nerve, and you can see that stimulate distally, you get a normal response. This is where you get block of 1, 2, 3, 4 fibers at this focal site. So these do not go through. There's normal temporal dispersion, so your amplitude is just lower. And here is a real example. This slide is only to point out that if you have people with CIDP and you look to see, is there also secondary axonal loss? There is. For example, you can have a 27% loss of axons going to the anterior tibialis muscle, and there are changes in the muscle. So if you look at, this is the gastroc soleus of a person with well-treated CIDP compared to a healthy person, and there are a lot of secondary changes in muscle due to axonal loss and probably other factors. Now I want to turn to diagnostic criteria. And so how were they originated? Well, first of all, it's consensus expert opinion, then some modeling, and then they try them out on patients and they make refinements. And the criteria are based on showing how much slowing there is, so distal latency, conduction velocity, F-wave latency, and temporal dispersion, and how many nerves have to be abnormal. And the criteria vary quite a bit, from very poor sensitivity to good sensitivity. Now, as time has gone on, there's been a refinement in the criteria. And the original ones that were found to be perhaps the most useful were the EFNS PNS criteria in 2010. And then in 2021, they're revised, name changed slightly to EFN criteria. And so they used to, in the older criteria, have definite, probable, and possible CIDP. Now there is typical CIDP, and there are variants. And the variants are very rare, and they're this distal acquired demyelinating neuropathy, or DADS, the various multifocal neuropathies we talked about, focal meaning CIDP in a single nerve, motor only, and sensory only. I also point out here that the criteria do not include this chronic immune sensory polyradiculopathy, nor does it include anything related to monoclonal gammopathies. Now, they have narrowed it down to typical CIDP or supportive CIDP. And this is all in fine print. And you can see distal latency, conduction velocity, F waves, etc. And these are the criteria. They are complicated, I grant you that. And then they also added criteria to sensory nerves. The sensory nerves may be absent, but if the sensory nerves are present, there are some criteria for them. They also spell out in great detail the criteria for these variants, typical DADS, etc., also very rare. Then there are criteria for conduction block. And the conduction block is basically the proximal response needs to be 50% lower than the distal response in the setting of a minimal increase in negative peak duration. If you fulfill a greater than 50% drop and no significant increase in negative peak duration, then that's true conduction block over pseudo conduction block. Now, what are the diagnostic challenges? Well, the formal criteria, as you saw, were very complicated to look at and to apply. And so I am trying to alert you to these simplified guidelines that we talked about for ALS. Therefore, if your slowing is greater than 75% of your conduction velocity limit or 125% of your latency limits, that suggests that there's greater slowing than axonal loss. Then consider primary demyelination, and then you can go back to the formal criteria. If the proximal amplitude is less than 50% of the distal amplitude, then likely there's an element of conduction block. There may also be abnormal temporal dispersion, but at least an element of conduction block. So I advocate, at least clinically, using these simplified guidelines. And so what I've done is taken here in black our laboratory's limits of normal, and then I've calculated the 75, 125% limits of normal in red, and then I can easily look to see if the patient is in this range or this range for any of these metrics. And the same thing for the negative peak duration. If it's greater than 9 milliseconds, then think about abnormal temporal dispersion. Okay, another caveat is in CIDP, not all nerves are affected. So here are some data that we had from patients who clinically had a diagnosis of CIDP, meaning their nerve conductions overall fulfilled criteria at that time, and they responded to treatment. And so here we have distal latency conduction block and conduction velocity and F wave latency, arm nerves and leg nerves. And here are the limits of normal. And you can see that there are very few data points that are in the normal range for people with CIDP. So don't be too surprised if not every nerve in a patient with CIDP fulfills criteria. Then the other challenge is someone with a diabetic neuropathy. We appreciate that nerve conduction studies in people with diabetes can be a little slow. And so here are some data where you see this outline represents normal nerve conduction, distribution of conduction velocities in different nerves. And then the shaded in area represents people with diabetes. And you can see that, and this would be where the limits of normal are. And so you can see they are slower than the limits of normal, but not in the demyelinating range. So again, here's some data that we collected. Same CIDP patients I showed you on the previous slide. Here we've added in diabetic patients, only looking at conduction velocity for simplicity. So you can see that there are patients with CIDP whose nerve conductions are in the normal range, and there are patients with diabetes whose nerve conductions are slower, but only a very few are slower than 75%. So you can see that number I told you is very discriminating for primary demyelination and to exclude patients with diabetes. So going back to the early slide, why are there so many inaccurate diagnoses of CIDP? It turns out it's not because the nerve conduction values that were generated were inaccurate. There were interpretation errors. And you can see here are some of the diagnoses of the erroneous that they ultimately turned out to be. And most of them are due to mild slowing of conduction velocity based on a mildly low compound potential. So misinterpretation of slowing to demyelination when in fact it was normal nerve conduction from a reduced number of axons. Now, there's one other diagnostic error I want to point out, and that is hereditary neuropathies. And you can see it's uncommon to see Charcot-Marie Tooth neuropathy 1A, but it has very characteristic slow conduction velocity. This patient had 18 meters per second, as did this patient. This one had CIDP with a prolonged distal latency and a ragged outline, and this patient had a normal negative peak duration and no raggedness to the outline. So if you see this pattern of slow conduction with normal temporal dispersion, that's highly likely to be CMT type 1A. Now, there are a few technical issues, and one important one is that you want to make sure that your electrode is positioned appropriately to get the highest amplitude. Here's a study where people put their recording electrode here as an example on the abductor pollicis brevis muscle, and we stimulated, and all these waveforms look good, but the lowest waveform was only 6.7 millivolts, and the highest one was 10.3. So what was the difference? One is the slope. So the steeper the slope, the higher the amplitude. So you cannot determine this point anatomically. So the only way is when you do your nerve conductions, if the slope looks a little shallow, move the electrode a millimeter or two and see if you can't increase the amplitude and slope. The second one, very uncommon, but occasionally the marking algorithm in your EMG machine will put a duration here in a very irregular waveform when in fact the duration should be here. So always look at your waveforms and how the marks have been placed. And then the other issue is, could you have very proximal demyelination that you miss? And so it's very difficult to ensure that you have adequate stimulation when you stimulate at Erb's point or try to stimulate at nerve roots. An alternative is neuroimaging. So one or two more caveats. I told you the distal amplitude cannot be less than a 1 millivolt in amplitude to assess for conduction block. Tibial nerve cannot be used for conduction block because the proximal response is usually much, much lower, even in normal people, not due to block. Going across the fibular head is challenging, and it's the site of entrapment. And the median nerve stimulating at the axillary region can activate the neighboring nerve. So let me move on to the EMG, and this is going to be titled Quantitating EMG Metrics. But you say, well, don't we quantitate them? We use 1+ and 4+ increase or decrease. But clearly, one person's 1+ may be another electromyographer's 2+. And so these 1 to 4+ values are ordinal numbers, and it's a relative ranking. If we can use discrete numeric values, then we allows for statistical analysis and clear and precise comparisons. And if they can improve the diagnostic accuracy when we're looking for subtle changes, which I'll illustrate later on. It does require special software, but usually you could talk your EMG provider into perhaps giving you the software. There's also another technique I want to tell you, which is simple and available on all machines, that gives you a semi-quantitative measurement. So let's talk a little bit about what we're doing with the EMG, and that's the motor unit. And this was a concept that's very simple, put forward by Sir Charles Sherrington in the 1930s. It's the alpha motor neuron in the cell body, the axon, all the intramuscular branches, all the neuromuscular junctions, and all the muscle fibers. And so I would say the goal of EMG is to estimate features of the motor unit to determine if it's normal or abnormal, and if abnormal, whether it's a neuropathic process or a myopathic process. So here is the motor unit in diagram. Here's the cell body, here's the axon, here are the branches that are myelinated with decreased amounts of myelin. And here are all the neuromuscular junctions as it connects with all the muscle fibers. So here are some of the questions I have in red that we would like to know when we do our EMG, and that I'll try to answer for you. So the first is, how many motor units are going to a muscle that we study? Well, they cannot be counted anatomically. There are estimates and attempts at counting, which I'll show you, but it's not something you can count. You can make some electrophysiologic estimates in certain muscles, not all of those we put a needle in. And this is by motor unit number estimation, MUNE or MUNI. Now, when people have done this, there are good comparisons between the anatomic estimates, and here I'm showing you a series of muscles where both electrophysiologic, MUNE, and anatomic estimates have been made. And you can see that there's a fair degree of variability amongst muscles. But if you want to have a couple of numbers in mind, from each technique, it's 100 to 400 motor nerves per the fibers in a nerve going to a muscle that we commonly study. Now, how many fibers in the motor unit? Well, again, you can count all the muscle fibers in a motor unit, and if you subtract your estimate of the number of nerve fibers going there, then you come up with this value of 140 to 2,000 fibers, again, depending upon the muscle. The next question is, how are the muscle fibers of a motor unit arranged? That is, what is the fiber density? Now, you can only view a motor unit in detail in a destructive experiment in an animal. And so this is what you see in the rat. So this is a cross section through the muscle. And every one of these light profiles is a muscle fiber depleted of its glycogen. And since they isolated a single axon, this is a single motor unit showing its distribution of glycogen depleted muscle fibers. Now here's a similar experiment in a cat where each dot represents a glycogen depleted muscle fiber. And here is an outline of the territory of the whole motor unit. And this is a fiber density histogram of the fibers in the motor unit. So here they're relatively few. Here there's a high density. That's what you see here. So you can see how they're distributed. Now, what's the area of a motor unit within a muscle? So we're back to what I showed you before. This would be one area in the rat, and then with different rats, because one motor unit per animal, you can see that the motor units do not take up the whole area of the muscle. They're in discrete segments. Now, recently, an interesting study has been done in humans where you can stimulate a single axon and do a special MRI sequence. And in different leg muscles, you can highlight the territory of a motor unit in that muscle. And you can see for this one study, they had different shapes: ellipse, crescent, circular, spider, and split. So yes, this idea of occupying a portion of the muscle in animals is holding up with the limited human data. And here's another human data where they took a special electrode with multiple ports and put it into the biceps muscle going across and deep and recorded from a single motor unit. And you can see its signal, as I've put bracketed here in red, spans about 10 millimeters. So within a human, the motor unit is up to 10 millimeters in diameter. So back to that earlier slide, I hope to have shown you that we've got 100 to 400 motor units in an average nerve, at least going to the muscles that we study with nerve conductions. I didn't talk about the role of myelin, but you can see that the myelin gets thinner as you get out toward the end branch, and the conduction velocity slows. And this is what makes up part of the residual latency in our motor nerve conduction studies. And then we didn't talk about jitter and neuromuscular junction transmission, but that's the security, and I'll talk briefly about that in a moment. What's the territory? It's about 10 millimeters in cross section. How many fibers are in there? Lots, 10,000 to a million. And what's the fiber in a whole muscle? And what's the fiber distribution within a motor unit? There are very few fibers of the same motor unit that are touching or adjacent to each other. Now, that's the anatomic motor unit. What we see is the electric motor unit or electrophysiologic motor unit. And that's dependent upon the size and configuration of our electrode. So A and B are concentric and monopolar electrodes that we frequently use. And although they have very different recording shapes and territories, they're seeing about the same number of fibers in a motor unit. A single fiber electrode is very special. It only sees 1 to 2 fibers of a motor unit. A macro electrode, used mostly as a research tool, can see the whole motor unit, but not in great detail. And then, of course, the surface electrode sees the whole motor unit, not in great detail. Although there are differences in the shapes of the concentric and monopolar electrodes, the main difference is a small, greater amplitude in monopolar electrodes compared to concentric electrodes. Now, when you put an electrode in, at least for concentric electrodes, it can only see 7 to 15 fibers of a motor unit. And then if there are 5,000 fibers of the motor unit elsewhere, they are beyond what it can see. And you don't really know the distribution of fibers in a motor unit. And so the electrode is randomly inserted. And so you can see that here it's close to 2 fibers, which gives you this waveform. Here it's close to this fiber, and then these are by the cannula, so you get this waveform. And here the electrode is not, tip of it is not close to any fiber, but the cannula is, so you get a cannula potential. And these are the major metrics we look at: the amplitude, the duration, the number of phases and turns, and recruitment. So this is just to show you that at any given electrode site in a muscle, there may be the territory of 20 or so motor units overlapping. And so this electrode is going to only be close to 5 to 7 motor units of any of the overlapping motor units. As I'll show you in a minute, the amplitude is dependent upon the 1 to 3 fibers that are very close to the tip of the electrode. So here's modeling, and you can see here's distance of fibers. You're going out here to 0.5 millimeter. And so you can see that the amplitude is higher when the electrode is closer to within about 0.5 millimeter. That's why they say that the amplitude comes from the nearest 1 to 3 fibers, especially 0.5 millimeter away. Also, that shows up in different rise times. So when you're very close to a fiber, the high frequency components show up. And when you're away from a fiber, the low frequency components are there. And here is a drawing of the very highest frequency components associated with a spike and the more lower frequency of components associated with shallow or more distant contributing fibers. So that's the amplitude. You want to optimize the amplitude by moving it closer to fibers. Now, duration. A lot of people focus on duration, and there are two durations. There's a physiologic duration, which we don't measure because it's very long, requires very high amplitude gain, and must be averaged 1,000 times to see it. What we're looking at is the clinical duration, and it too is based on amplifier gain and background noise. So here's a picture of the very same motor unit at different gains. And here you can see the durations. And they range from 6 milliseconds to 12 milliseconds as estimated visually. And then here's a little sample if we had time. How many people think that this A ends at 1 or 2, and B ends at 1 or 2, and C ends at 1 or 2? So you can see it's highly subjective of how you estimate duration. Then phases and turns. Keep in mind that a phase is a portion above or below the baseline. Also to appreciate that the definition of polyphasic was a motor unit that had greater than 4 phases. Now a turn is a change in voltage, but the turn has to be a certain distance between turns. You can't have just a noisy line, doing this, and all those little changes count as turns. So generally, it has to be a turnaround with 100 to microvolt voltage difference between turns. And a polyturn is a motor unit that has greater than 5 phases. This shows you that as you move the electrode, you can convert turns into phases and have different amplitude. So don't think just in terms of phases and turns, think of both of them. And if you have an increase in one or the other, think of it as a complex motor unit. Now, recruitment's a real challenge. And so keep in mind that a motor unit does not discharge regularly. It is an irregular discharge. And you can calculate an instantaneous frequency, which was 1 over the period between the discharges. And that's what's shown here. This is the instantaneous discharge. And then here we have increase in force. And now we're recording from 3 different motor units. And so there's an onset frequency of 3 to 5 hertz. So this motor unit begins discharging at about 3.5 hertz, this one at about 3 hertz, and this one here at about 4 hertz. So it starts at a certain onset frequency. And then as you increase force, you do 2 things. One, you can have frequency increase. And so here the discharge frequency increases until you get to a frequency where you bring in the next motor unit, which is spatial recruitment. So this one discharged to about here, and then it brought in the second one. And this one discharged to about here, and it brought in the third one. Now there's a proximal maximum of about 50 hertz. But if you were to put full effort into a muscle, it may get as high as 70 hertz. But the key is that few normal motor units discharge at greater than 15 hertz. Now, here's an interference pattern you can see going all the way up, and we can't really see very much in here. So most of our motor unit analysis is in this low, relatively low recruitment as measured by maximal voluntary contraction. It's in the 10 to 15% range. So one thing I want to point out to you is that if you have the weakest contraction, you're going to be recruiting smaller motor units. As your contraction increases, you're going to be increasing larger motor units. And that's important when you try to estimate the size or the amplitude of a motor unit. So let's go on to motor unit pathology. Well, here's the same picture I showed you before of denervation, no matter where it is, causing collateral reinnervation. Here is the same picture I showed you of a normal motor unit. And here's a motor unit after there's been denervation and reinnervation in the rat. And you can see that there are now clusters of muscle fibers innervated in the same motor unit. So the density of fibers has increased. And in part, this is what you see with fiber type grouping on muscle pathology slides. So what you get is a larger motor unit in density. In a myopathy, here we've got a normal motor unit. Here we have the muscle fibers degenerating. And so what you would have is denervation of these muscle fibers if your electrode were here compared to the ones that are connected to the nerve terminal. And here's a segmental denervation that you see here on a muscle fiber. And then histologically in cross section, you're going to get large diameter fibers, small diameter fibers, loss of fibers, replacement of connective tissue. When you have small diameter muscle fibers, they're going to conduct more slowly. And so that will change the shape of your motor unit potential. Now, just briefly with qualitative EMG, which is most of what we use, the values that we get for normal, for amplitude, duration, phases, come from weak muscle contractions where they were photographed and measurements were made, and these are what we basically have in mind when we estimate motor unit metrics. Now, here's a slide that points out that with aging, so here you can see we have 25 to 30 in the 60s and the 70s and 80s, the number of motor units drop. So we're all losing motor units with age. In the 20s and 30s, we have 150 motor units, and the 70s and 80s were almost 60. With that is going to be collateral reinnervation, and with that is going to be an increase in the amplitude of the motor units and a small increase in duration. So keep in mind the age effect when you're studying older patients. Now, another point to keep in mind is even when you have clear pathology, motor units from patients with a myopathy or a neuropathy compared to motor units in normal patients, most of the metrics are in the normal range. Here's amplitude, normal range, a bit of outliers in myopathy and neuropathy. And then here is a ratio I'll talk to you about. You can see the area to amplitude ratio, mostly normal, a little bit larger in neuropathy and less in myopathy. And duration, which I just talked about, we talk about short duration motor units in a myopathy. Look, the majority of them are in the normal range. So what we're looking for in a disease state is outliers. And so here we have a series of 20 motor units from a normal person, and you can see that these look pretty good. When you look at a similar distribution of a person with a neuropathy, most of them look pretty good, but these are the few outliers that stand out from the rest that are normal. Now, when we are doing qualitative studies, we have bias. The bigger ones are louder and they stick up more on the screen. And then we have to look very hard for the low amplitude, very polyphasic motor units. And here I have a diagram of walking in a forest. If you're looking up at the tall trees, you're going to miss the intermediate ones and be biased for the tallest trees. And conversely, if you're looking up there, you're not going to find the small chirpy motor units or the small pretty flowered shrubs. So what we'd like to be able to do is to eliminate some of this bias by this quantification. And here, these values get put into a graph form, and you can see the outlying values. Very briefly, single fiber and jitter measurements, just because I'm going to bring them up later. So what we're looking for in single fiber is variability in transmission at the neuromuscular junction. It can be highly variable within a motor unit. And so here's a motor unit where this neuromuscular junction is normal, this one's normal, and the third one is normal, but there is a marked degree of variability in the fourth one. So keep that in mind. And that also occurs not only in myasthenia gravis, but also in reinnervation. Now, fiber density, I mentioned that the single fiber really can only see one or two fibers. And so here you're placing it close to one fiber here, and that's what you count. You place it to one fiber here, and there's another fiber in the recording radius. And so this would be normal fiber density. If your muscle has increased fiber density and you get your electrode close to one of them, you're likely to see several in the recording radius. That's increased fiber density or denervation, reinnervation. Now let me turn to the EMG machine. Now all EMG machines have a voltage trigger and a delay line and the ability to use that to isolate motor units. So what is a voltage trigger? So you can see here, you've got a sweep. I've just shown one. You can set this line here higher or lower, and then when the motor unit crosses that line, it puts it into another screen. If this were an analog oscilloscope, you wouldn't know what happened before the waveform crossed that line. Because we have a digital memory in our EMG machines, once it crosses that line, you can look backwards in time, scaled as the number of divisions. So if we move this out by one division, we see a bit more, 2 divisions, 3 divisions. So we can isolate a motor unit by capturing it, putting it into another screen, and now we can spread it out and we can look at amplitude and duration very carefully. So that's the voltage and trigger system on any EMG machine. This gets me to semi-quantitative EMG. So here is one way of setting up an EMG machine. This is your free run screen where it sweeps by at whatever speed you have. Then you can capture one of these, move it over here, and you can look at it in detail now at 2 milliseconds per division. When the second one comes over and is captured, this one gets moved down here, and you see the second one. And then this repeats, and you store about 15 of these. And when the 16th one comes, the first one drops out. Then you're saving between 2 and 16 and so on. What you have a chance of doing here is seeing that clearly this motor unit in here is very stable, and there are other motor units in there, but you can get a very good picture of this particular motor unit in a semi-quantitative fashion. Now, I also recommend that you keep your screen on 10 milliseconds per division. Some people use 20, but I don't think that your macular visual acuity, if you look carefully, intently in here, is going to see the whole screen. So I don't think you're getting as much out of a 20 division screen as one thinks one is. And there's an advantage, which I'll show you here. If your free run is at 10 milliseconds per division, and you have 10 divisions, it takes 100 milliseconds to sweep. Therefore, it sweeps 10 times a second. If you had a motor unit that discharged exactly 10 hertz, it would stay the same position in that sweep. If you had a motor unit that discharged at 11 hertz, 11 hertz, then in successive sweeps, it would be captured earlier. If it discharged at 9 hertz, it would be captured later. If it discharged at 20 hertz, you would see it 2 times per sweep. Now, therefore, when you get a motor unit that you can look at and it discharges greater than 20 hertz, that would be decreased frequency, and you can list it as 20 hertz or 30 hertz, or occasionally you'll get one motor unit that's discharging 5 times per sweep. So instead of putting 4 plus decreased recruitment, put down 40 or 50 hertz. Also, in that superimposed screen I showed you before, you can estimate the largest motor unit of about 4 in here was 1.6 K millivolts, and the duration of these was about 6 milliseconds. So you don't have to put in pluses and minuses, you can put in some rough values. Now, for formal quantitative EMG, you're letting the machine automatically isolate more than 20 motor units from that muscle. And that's a sufficient number for statistical analysis. And the metrics that you're getting are not only the routine metrics we just talked about, amplitude, duration, phases, and turns, but there are some derived metrics, which I'll show you in a minute. And then in a minute, I will get to advanced analysis with near muscle fiber features. And finally, you have the statistical inferences to determine whether the muscle on average is abnormal or not. So here we have just an interference pattern just in successive raster format. If we used the photographic measure as Buchtal did, or we use the isolation, we only may be able to really see 1 in 5. So we're only isolating at a weak interference pattern, perhaps 2 motor units per site in the muscle. Now, if we use computer-based isolation, then in about 10 seconds, you've got 100 sweeps, you can isolate 3 to 6 motor units here. And so I've got, I'm just showing you the ones that it could easily isolate. It would see number 5, motor unit 5, a number of times, average them and give you the output of the average. And then number 1, it may see it at 15 or 20 times, give you that average. And so when it extracts it, you're getting, with about 5 sites in the muscle, you're getting more than 20 motor units. You're getting the full spectrum of the metrics. And you can do this at higher intensity contractions, which will give you both small and large motor units. So as I pointed out, you're going to get the average, but outlier values. Keep in mind that the duration is set automatically by an algorithm, so it's going to be consistent, and it'll give you the average phases and turns. Now, here's the derived metric, which is the area to amplitude ratio. Now, it's important because the amplitude varies by how close you are to the single nearest fiber from the electrode tip. And so the amplitude is very proportional to how close you are to the fiber, but the area is less proportional. So if you have an area to amplitude ratio that is low, that's more consistent with myopathic motor units. And if you have an area to amplitude ratio that is high, that's more consistent with neuropathic motor units. So here's a derived metric that you can't get with qualitative EMG, but you can get with quantitative EMG. And then there's another one, which is stability of the motor unit from discharge to discharge. You can roughly estimate that with the triggered and raster format, but the EMG machine can calculate this time variability and give you an accurate number measured in microseconds. And that's stability of the motor unit, which is important if you have reinnervation. It's going to be less stable and is hence a sign of active reinnervation, such as an ALS. Now, what does the output look like? Well, here's the output of one EMG machine. You can see here it's isolated 5 different motor units, shows you the average of the 5. This is the raster. You can see whether the waveforms were contaminated. And this is the discharge frequency. And over here is the table. Now, this is just 5, but if you collected 20, it would give you the average peak-to-peak voltage. It would give you the air-to-amplitude ratio. It would give you the complexity in turns and phases and the stability. Now, you have the ability to edit these things. Now, here's another EMG machine's output where now we're looking at one of these. This is the raster that went to make up it. And this is the table for, in this case, the left deltoid. It gives you the amplitude of the individual motor units, their duration, and it gives you the average of all of them. And here it highlights outliers. Now, you may say, okay, if I'm using Buchtal's numbers at low rates of forces of contraction, and now I'm using higher forces of contraction with larger motor units, what am I going to call normal? Do I have to get my own normal data? The answer is yes, but it's relatively straightforward. What you have to do is to go into your EMG machine and take your metrics such as amplitude and duration and phases and turns from all patients from that particular muscle, independent of whether that was a normal muscle or an abnormal muscle. And if you plot, in this case, the amplitude in ascending order in the blue line, you can see it goes up fairly linearly and it gets to a certain amplitude when it goes way up. And so this would reflect the break between normal motor unit amplitudes and abnormal motor unit amplitudes. And you could very easily put a straight edge across there and estimate where that is. And so that's 2,200 microvolts. So this muscle, this type of electrode, your way of doing the study, when your amplitudes become greater than 2,200 microvolts, then you think it's pathologic. So you can do the same thing for your other muscles and collect your own normal values. Now, how much time does it take for a quantitative EMG? Well, let's take the extreme. I've seen some outside studies from certified laboratories where in an individual patient, they studied more than 40 muscles. Now, for quantitative EMG, the goal is to choose a muscle that you think is going to give you the answer. Is it a neuropathy or a myopathy? And perform that on a limited number of informative muscles. And so that would take less time than trying to isolate 40 different muscles in a patient, let alone the discomfort to the patient. So you may do a routine study on some muscles and a quantitative study on other muscles. So what are the interpretive values? Well, it's going to be more objective. It's going to be less influenced by the large and loud motor units. And you should have fewer false positive and false negative diagnoses. You get the derived metrics. And let me give you an example. So if you have a patient who you think has ALS and it's fairly early on and only some muscles are clearly involved with atrophy, you want to look for subclinical involvement. And you may or may not see positive waves and fibrillation potentials. But if you can see unstable motor units in clinically normal muscles, that's very supportive of a subclinical denervating disorder. Another example is if you're concerned for a chronic radiculopathy and you think the motor units in a representative muscle are a little bit larger than you expect, what you could do is quantitative EMG in that muscle on the affected side, then the same muscle on the unaffected side, and then you would have a much clearer determination of whether the motor units are truly enlarged or you're just thinking they are. Now, let me just end with what I think is the next and quite exciting iteration, and that is we talked about single fiber electrodes looking at single fibers, but that's a special electrode in a separate study. We can now extract a representative of single fibers called near fibers from the regular concentric motor unit waveform. You can get a fiber count, which is not fiber density, and you get it the average for the whole motor unit, and hence you can add that up for the whole muscle. And you can get a degree of neuromuscular variability, which is not pure neuromuscular jitter, but represents a degree of variability. And so here is just a simple example. You've got a motor unit from a normal person, that with a neurogenic disorder and a myopathic disorder. And when you look at these, they're not strikingly abnormal, especially for these two. But if you go over here and look at the near fiber count, normal it's 4, and this one it's 7, and this one it's 11. So you'd never appreciate looking at this that there are 7 fibers contributing maximally to this and 11 fibers contributing to this. So this suggests there's pathology in there. And then when you look up at the amount of jiggle, you can see here with the blue, it's 15.7% in the normal muscle, and here it is 41.5%. And this is the variability in transmission. So you can see that we have the ability to almost do a single fiber study every time at the same time we do our concentric study using quantitative EMG software. Now, I've just showed you an evolution from routine EMGs to quantitative EMGs to near fiber EMG. Now, there's another way of looking at this, and that is using what we'll call artificial intelligence or expert systems, and it's a Bayesian probability of the state of a muscle. So, for example, you can do an EMG, and from a training muscle, in other words, you can have motor units taken from people who have unequivocal neuropathic muscles or myopathic muscles, and get the range of motor units. I told you most of them will be normal, but get the range of abnormalities and call that a learning set. And then when you collect a motor unit from a patient, you can compare the metrics, and it will tell you for that motor unit what the percentage is. That motor unit is 25% neuropathic, or could be 25% myopathic, but it's 50% in the normal range. And then you collect another 20 or so motor units, giving you the same probability of the state of that motor unit. Then you combine all of these into the muscle, and then you can say that the muscle has a probability confidence of 0.6 that it's a myopathic muscle. It's got 25% could be neuropathic, 25% could be normal. So this is a way of making a definite statement about a muscle based on probability versus based on your hunch or your clinical guess or your experience. So how to put this together? I've tried to show you what estimate the electronic motor unit is of the anatomic motor unit, the limited metrics that you get, and how you can enhance them with QEMG software. And I hope that at a minimum, you can try this semi-quantitative EMG with the voltage, trigger, and delay line, which is available on any EMG machine. So I've taken quite a bit of time. I think I've covered quite a bit of area. I hope it has been informative for you, and I'm happy to entertain any questions.